So thank you very much for the opportunity. And what I'd like to speak today about is both an interesting intersection between an atypical area of pharmacogenomics interaction, but also kind of an atypical use case and setting for our implementation of this information. So specifically, we're looking at genetic variations in RYR1, CACNA1S, there should be an S on there, and their relation with malignant hypothermia. So malignant hypothermia is a hypermetabolic crisis associated with exposure to our volatile inhaled anesthetic medications, our fluorines, enflurane, halothane, desflurane, as well as succinylcholine. And this is a very rare reaction affecting only about 1 in 100,000 patients. But historically, up until a couple of decades ago, or up until about a decade or so ago, the mortality associated with this when it arose was 50 to 70%, a very high mortality condition for these patients when it did arise. With modern support, the ability to both detect, screen, and also treat this more readily, that mortality is down to 6 to 10%, but obviously 6 to 10% mortality is still quite high. Malignant hypothermia typically is going to present initially starting as unregulated release of these calcium ions into the intracellular space. Going to lead to sustained muscle contractions, and then that's further going to lead to hypercarbia, tachycardia, muscle rigidity. So we have our muscles that are rapidly contracting and they're unable to uncontract. The heart is beating more rapidly. We are starting to see an increase in our CO2 in our blood level. And those things all together are going to lead to increasing acidosis. I believe that like a mixed metabolic respiratory form of acidosis. And then the muscle rigidity and that continuous contraction is then going to further lead to muscle damage or rhabdomyolysis. And these things together continuing are going to lead to gradual increases in the body temperature as that muscle, the muscle contractions are generating heat the same way shivering does, and leading to eventual hypothermia. So this is a very significant condition that, again, only affects about 1 in 100,000 patients, but we do have genetic factors, genetic markers that lead to increased susceptibility for this interaction. 3 main genes have been studied for their relation to this condition. The ryanodine receptor, RYR1, dihydropyridine receptor, DHP, and then the STAC3 receptor have all been linked to increased susceptibility to this condition. We're primarily going to focus on the first 2, the RYR1 results, and then CACNA1S is a subunit of that receptor. So that gene, that CACNA1S gene, is part of that DHP receptor. The third one there, we'll look a little bit about the CPIC guideline in just a second. It's covered in brief there. This is primarily a gene that's more going to be focused on like a medical genetics side. It's more associated with STAC myopathy, which is found in Indigenous American populations, leading to congenital defects, more physical presentations, and is associated with this reaction, but also a slew of other things, and is kind of treated on its own because typically the patient's going to be diagnosed with that fairly early. The majority of patients that have one of these malignant hypothermia episodes have been found to have a genetic component, a genetic predisposition that then leads to that occurrence. And importantly, not all patients that have these results will necessarily experience this, but they are at that increased risk. Because of these genes and their potential clinical impact and the severity of that impact, there is a CPIC guideline, a Clinical Pharmacogenetics Implementation Consortium guideline, that has been written specifically to address how to utilize these results in our clinical practice, how to recommend alterations in therapy for patients that have any of these specific factors. The patients are divided into two groups, basically patients who are uncertain susceptibility, basically a result that is either not associated with these results, a result that's not associated with this condition, or a result that is wild type and not expected to be any different than the normal population average. Or more importantly for our patient case today, our patient discussion today, patients that are at this increased risk. And there you can see the dosing recommendations are these medications are contraindicated, they should be avoided. If they are used, then really should be sure that benefits are outweighing those risks and that we are making sure to properly screen and monitor for MHS as much as we can. If you have a patient that develops this condition, how do we begin to treat them? So the first thing, because this is going to be so institution specific, so related to your institutional anesthesia policies, your emergency policies, the first thing you want to do is ahead of time, be aware of what your hypothermia protocols are, and then begin to activate that institutional protocol. Typically, those are going to start with discontinuation of the triggering agents, notification of the surgery team, because typically this is going to be noticed and discovered first by the anesthesiologist, and depending on the connection and discussion between those teams, sometimes those are more or less connected. So you want to make sure the surgery team is aware immediately, because it could impact the progression of that surgical procedure. They may need to abort early. They may need to rapidly assess whether they need to somehow get that surgery ready for discontinuation, maybe before they were initially ready. And then also optimization of oxygenation and ventilation, making sure this patient has a clear airway and oxygenation levels are high. For treatment, dantrolene is a basically the main, if almost only, antidote agent for this. Generally, it's going to be given at about 2.5 mg per kg every 5 minutes until symptoms improve. This could again vary based upon your departmental specific policy, but that is the most common standard dose. And then following this, in the recovery phase, after the patient starts to return to baseline, we want to institute a cooling protocol, significant monitoring for both continued deviations in temperature, but also for any lasting effects, either through the rhabdomyolysis, impacts on other organ function that may arise from that damage, and just making sure we're fully appraised of how impactful that was. How do we treat patients that have one of these effects? What are some non-triggering alternatives we can use? Oftentimes, many of these are already going to be used in addition to one of the quote triggering options as well, because we do want to make sure patients have proper pain relief. We have supportive care for antiemetics and anxiolytics, but common alternatives include things like IV anesthetic or sedative agents such as propofol, ketamine, etomidate. This is where it's going to be very, not necessarily even departmentally specific, but also very specific to that particular anesthesiologist's perspectives, their preferences, and the procedure. So it's difficult to know exactly which medication should be used instead. And that's why it's very important for the anesthesiologist to be aware of this early enough to really take that into their planning phase for them to determine what best medications for them to use. One of the more common medications we have seen, both at our institution and just referenced in the literature as an alternative, is utilizing propofol. And there are some good benefits, but some potential concerns when we utilize propofol. It has a very rapid onset, very short duration of action, so you can really wean the patient's sedation levels to the desired amount. Also can decrease intracranial pressure, which could be beneficial to some use cases where the patient may have either an intracranial injury or you're concerned for some potential residual pressure. And also no adjustments for renal or hepatic dysfunction. So there's a lot of benefits to using this. However, there are some concerns. We can see some hypotension, some respiratory depression, which seems to be decently common with most of our anesthetic options. Propofol also, because of its lipid component, can also lead to some hypertriglyceridemia. And then also propofol-related infusion syndrome is kind of the more prevalent, maybe not necessarily common, but it's one of the more prevalent points of discussion you may see when you hear propofol use becoming more common. So what is this propofol-related infusion syndrome? It is a fairly rare complication of propofol infusion that again has potentially high mortality. So what we definitely don't want to do is avoid one potential rare complication with high mortality and then potentially instigate another potentially high mortality rare event. This propofol-related infusion syndrome is typically comprised of severe acidosis, refractory bradycardia, again, rhabdomyolysis, some hyperlipidemia. Beneficially or fortunately, is typically only seen in situations of high and long doses where the total load of the medication is quite substantive. So generally not seen for common surgical procedures, but could be seen for patients that are using this agent for a long continuous sedation. Treatment is typically through immediate discontinuation and then supportive care. So what might this look like as just an example patient? This is just a quick review of one of the patients we've seen at NorthShore, just in brief. This patient was a 45-year-old patient with upcoming surgical procedure. They required general anesthesia. They had multiple surgeries in the past and had also had one within the last year in which they used sevoflurane. Within that last year, the patient also completed genetic testing. And during a pre-surgical visit, they notified the provider that they remembered from the discussion that the report said they don't respond well to anesthesia. And this is pretty common with what patients will use as their phrasing or their wording. They don't necessarily remember the gene. They don't necessarily remember the exact impact. They'll just remember, I don't respond well to this category of meds. So it's important then to look deeper into the exact interaction that they're clarifying. And this provider did that. Upon review, they noticed this patient had that variation in RYR1 that leads to that increased risk of malignant hypothermia. And even though they had been exposed to those agents within the last year without incident, that does not necessarily rule out the potential for this. So in this, just quick case, the patient reviewed the results with their provider. The provider reviewed those results, discussed with the anesthesiologist, and then we saw this patient receive propofol instead of the prior triggering medication. So one last slide before we just stop for questions for a second. This is just a quick breakdown of what we've seen at NorthShore for this use case. So today we've had 39 patients that have been positive for these gene results. Of those, 23 have had at least one surgical encounter. So not every patient that even has this result necessarily is going to have a surgery. But it's best to make sure that we are informing those patients, not necessarily even when they get the results, but when they are going to be using them. We've had no instances of malignant hypothermia been reported within our test patient population, or I even tried to find cases outside of that test patient or outside of our tested population. I have not been able to find any cases of malignant hypothermia within the last 5 years, which is good. We did have 2 patients within this reviewed group that had surgeries both before and after the return of results. In both cases, at the initial surgery, they received a potentially triggering medication while having a result that could give them increased chance of this syndrome. And neither one had symptoms, but upon second procedure, after return of results, they did receive an alternative medication. And in all cases where the results were available before surgery, a triggering medication was not administered.